Thank you very much for having attended the webinar on Breast Cancer 101. We had over 1,400 women signed up to listen to new thinking about breast cancer. And although we answered a lot of questions, there were still some questions that came later or that we didn't get to. And I wanted to take an opportunity to answer them for you, because we really like to make sure that everybody is clear and has everything that they want to know. The first question that I want to answer is for Sister Rosemary, and she asked me about Avista, and which she's taking for her bones, and whether the new news that there might be abnormal fractures from some of these drugs might mean that she should stop it. And the answer is Avista is actually a very different kind of drug than, say, Fosamax or some of these other drugs. Avista is much more like tamoxifen. It's a selective estrogen receptor modulator, which is a fancy way of saying that in some organs it acts like estrogen, and in other organs it blocks estrogen. And in the bones it acts like estrogen. And so it is actually good at preventing fractures, and at the same time it blocks estrogen in the breast, so it reduces breast cancer risk. So it's a reasonable drug to take if you do have osteoporosis. The other drugs, Fosamax and other drugs like that, Boniva, those drugs, actually block bone resorption. So they interfere with how the bone itself works. And those are the ones where we've found if you take it for a long period of time, you may get abnormal fractures in your legs. So it's really two different classes of drugs. So I hope that answers her question. The next question is Elizabeth, and she has BRCA2, and they was told she has a 50 to 80% risk of getting breast cancer, and wants to know, how do I think about that? Well, there are two kinds of genes that you can inherit for breast cancer. There's BRCA1, which stands for breast cancer 1, and BRCA2, which stands for breast cancer 2. And these genes you inherit either from your mother or your father, and they're in every cell in your body, and you can have a gene test to see if you have it. They're only responsible for about 5 to 10% of all breast cancer, however. But in those women who carry the gene, we know that statistically speaking, there is a higher risk of getting cancer, both in the ovaries and in the breast. And Elizabeth did mention that she had cancer in the ovary already and had it treated. So I'm assuming that when she had her treatment for ovarian cancer, she had both her ovaries out. And interestingly, if you have your ovaries out, you reduce your risk of getting breast cancer by 70%, which is really a lot. So in fact, although she's worried about getting breast cancer, the fact that she's already had this treatment means her breast cancer risk is now already lower than that 50 to 80% she was originally quoted. She could, if she were really interested, have bilateral mastectomies, which would reduce her risk even more, but she's already in a pretty good shape. So I hope that helps you, Elizabeth. Carol wanted to know if mothers of children with Down syndrome have a higher risk of breast cancer. And I did some research just to check up on this, Carol, because I wasn't sure. And indeed, although there is one study that suggested maybe there was a higher risk, when you looked at it, the risk could be anything from 4% higher to 46% higher. And then other studies have not shown there to be an increased risk. You know, there are other issues about pregnancy. As we said in the webinar, women, while they're pregnant and for the next 10 years, have a higher risk of getting breast cancer because of all the changes that are going on in the breast tissue related to pregnancy, making milk, stopping making milk, all of that. And often women who have children with Down syndrome tend to be older mothers. It may be related just to being pregnant and not specifically to the Down syndrome. But I couldn't find any solid evidence to suggest this was the case. Then asked, she's had breast cancer and she's on Femara, and she had a total abdominal hysterectomy, so she feels like she doesn't have any estrogen in her body, and the symptom that's really bothering her the most is the vaginal dryness. And this is a symptom that bothers a lot of women postmenopausally, both those with breast cancer and those without. that the lubrication in the vagina is not as good once you get past menopause, probably because our bodies aren't encouraging us as much to have children at that time, God knows. At any rate, the best treatment is not the creams. You don't want to use one of those vaginal creams because they're very well absorbed and the estrogen gets into your whole body. What you want to use is either E-string, which is sort of like a diaphragm without the middle part, and slowly releases estrogen over a long period of time. In fact, you leave it in for 3 months. And that really doesn't give you much estrogen in your bloodstream, so that's safe. Or one of the tablets, where you put a tablet in your vagina, and that also is a slow release. And if she takes that, it should be able to solve the problem, the acute problem. Her other issue was libido, and that's really a harder issue, and we don't have a good answer for that. Some people have suggested testosterone to help libido, but in fact, testosterone is a real risk factor for breast cancer, and it hasn't been shown clearly to have an effect. So I would be leery of that. I hope that at least the other treatments will be helpful to her. Then Mandy, she had a mammogram, and then she had an ultrasound, and then the next time she showed up, they said they wanted to do a 3-dimensional ultrasound or mammogram, which was a new machine they had, but they wanted her to pay for it. And she felt like, was this really necessary? You know, companies are continually trying to get better imaging, whether it's mammograms or whole breast ultrasound or thermography, and so far none of these have been shown to really be of additional value. If they want to test them on you, to experiment in the sense of trying to see whether this in a good research study is better than a mammogram, then I think it's definitely worth it. But I really agree with Mandy that asking you to pay for it when it hasn't even been proven to work or to be better than a regular mammogram is not really something you want to do. Okay, another question was from Cheryl about thermography. And so thermography is something that's been around for a long time. It's a kind of imaging, and it measures the amount of heat in your breast. And the idea is breast cancers may have more blood vessels, they may make more heat, so then that would show up. It doesn't use radiation, and that's the benefit. But the problem is it's never been shown to be as good or better than mammography. And in fact, a lot of things in our breast can increase the heat, not just cancer. A lot of benign lumps, infections, you can have even a pimple on your breast and that would increase the heat. So thermography is still a technology looking for a use, and I still don't think it's worth doing. Another question about birth control pills, and do they contribute to breast cancer or the environment, and what about alcohol? Birth control pills are very interesting. All the studies that have been done have not shown an increased risk of breast cancer. However, they've all been done in young women in their 20s, 30s, because especially initially, these were the women taking birth control. What I do worry about is taking birth control pills in your 40s and 50s as you get closer to menopause. Because the amount of hormones in the birth control pill is actually not that different than the amount that the normal premenopausal menstruating woman is producing. And so you don't see an increase. But as you get to menopause and afterwards, then taking hormones, you're taking hormones and your normal body is not making hormones. And so now you're increasing the levels, and that may be more dangerous. And indeed, the way that hormones, the birth control pills or hormone replacement therapy would affect, or even fertility drugs for that matter, might affect breast cancer risk is by changing the neighborhood, by changing the other cells around the mutated cells and causing them, changing the environment so that then they're more likely to become cancer. It's like, getting more graffiti and there's more deserted houses and all of a sudden there's more crime in the neighborhood and there's less police. And well, these are all things that they change the fat cells and the fibrous tissue and the blood vessels and the immune cells and make it more conducive for the abnormal cells to get out, or to become more aggressive. And indeed, alcohol, if you drink more than 3 drinks a week, also changes the neighborhood. It's another factor that's a neighborhood changer rather than a cell mutator, as is exercise, diet, and weight, as we said in the webinar. Another question on the impact of COMT, C-O-M-T enzyme on estrogen metabolism and metabolites. I've looked up, I did a literature search because I was not aware of any data connecting it, and I wanted to see if that was the case. And indeed, these enzymes seem to be related to mental health and maybe related to depression, but I could not find any really good links with breast cancer. So this person who has both a mutation in COMT and had breast cancer, we have to look for another explanation. Another question is a woman who is 40 years old and had a mother and a grandmother, maternal grandmother with breast cancer, both fairly young, 49 and 56, and has very dense breast tissue and large breasts, and she's getting mammograms and MRIs, but she's worried and very nervous because she feels like she has these ticking time bombs on her chest, and what could she do? And she's doesn't carry the gene for breast cancer. And I think there's a number of things you can do. I realize your risk is, first of all, realize your risk is not that much higher than the average person because of your family history. You add the family history and the dense breasts, and maybe slightly higher. One thing you could do is to consider taking tamoxifen. Tamoxifen is a selective estrogen receptor modulator like the Avista we talked about earlier, and it has been shown in a big randomized controlled trial to decrease the chance of getting breast cancer, particularly hormone-positive breast cancer and DCIS. And you can take it for 5 years. It doesn't have a lot of side effects, and it's probably got its best advantage in premenopausal women. And the interesting thing about it is if you take it for 5 years and then you stop, the benefit persists for at least 10 or 15 years after that. So you don't have to keep taking it forever. It's a 5-year and then stop. So that's one thing, and you can ask your doctor about it. It's a generic drug, so it's not very expensive. Another is you could, the radical extreme would be consider having preventative mastectomies. That will reduce your risk of getting breast cancer, but it's pretty aggressive surgery. You might even consider having reduction mammoplasties. If you have really large breasts, reducing the amount of breast tissue does reduce the amount of risk. So even if you reduce the breast tissue by 50%, you would reduce your risk by 50%. And it would also give pathologists a chance to look at your breast tissue and see sort of if there is anything worrisome or scary in there. So those are a couple of different things you could do. I know it's scary, and it's not always logical. I mean, when we have a parent that died of something, we always think that's going to happen to us, even though it doesn't necessarily make sense. And so all of these things are things you can do that maybe would help you handle that a little better. I would go see, either go to a high-risk clinic or see a breast surgeon or go to a breast center where they really actually are experts in the breast, and don't just talk to your regular doctor or your gynecologist because they have less information. Okay, another question is a woman who is pregnant and has a 2.5-year-old and was nervous because I said there was an increased risk of breast cancer during pregnancy and after. It's true, there is an increased risk, but the other thing that's also true is it's not that high. I mean, if you compare it to people the same age who are not pregnant, it's slightly higher, but it's certainly not as high as it is postmenopausally, and it's not like I would say don't get pregnant so you won't get breast cancer. I had my first and only pregnancy at 40, which shows you how much attention I pay to all of this. These things are interesting in trying to understand breast cancer and how it works, but they doesn't mean that they really are going to function in every single person's life. So I think I wouldn't be too worried about it. She asked about screening, and she said that she had a mammogram and ultrasound prior to getting pregnant again, and I think that's fine. And then having another one, after she's finished breastfeeding is fine. Screening is not perfect. Screening misses a lot of cancers, and I think that's something that we don't talk about enough. We worry about the false positives, the things that show up on a mammogram that aren't cancer, but we don't talk about the false negatives, which is how many times you have a normal mammogram when you still have cancer. And so if she had, the one other thing is, if you notice a lump, if you notice something that's abnormal or different, get it checked out. Because the screening is not going to show up very well when you're pregnant or lactating. But if you had a cancer, you should be able to identify it, and you're more likely to do it than your doctor. Janet wants to know about, she was diagnosed in December of 2010, and she had a small tumor. And then when they did the pathology, they found microinvasion, and she's really worried, since none of this showed up on mammogram, how does she know there's not more microinvasion? And this means, what you have to do is go back to how we think about breast cancer. All breast cancer starts in the lining of the milk ducts, all of it. And the lobules are on the, on the edge of the branches of the milk ducts, sort of like leaves on a tree. And then those cells in the milk duct, sort of like rust, grow, and eventually they get out of the milk duct into the surrounding fat. We used to think they got a new power to break out of the duct, but now it looks more like the duct lets them out. It's sort of like having armed guards standing around a prison, and then you get them drunk and they just say, come on out, have a good time. Well, that's what happens when you get microinvasion. The duct is letting those cells get out. Now, microinvasion means there's not a lump, there's not a whole big tumor, but they see, when they look under the microscope really carefully at that duct, they can see places where they see a cell sneaking out or that just got on the other side of the duct. It's not enough to be a lump, it's not enough to show on a mammogram, and it's not enough to show on any other test. And so sometimes when you have a core biopsy that's only taking a little piece of tissue, it looks like one thing, and then when you have a bigger piece of tissue taken out and they look at it more carefully in more slides, they see other things. So that's why they found the microinvasion afterwards. It's not unusual, and it doesn't mean that the cancer is invading. Microinvasion doesn't mean it's getting into the rest of your body. It doesn't mean it's likely to kill you. And a lot of people think that even with microinvasion, it's got about the same prognosis as if you didn't have the microinvasion. It's just like being one day pregnant. You might end up having a kid, or you might lose a pregnancy early on. And so I wouldn't worry about it a whole lot. The radiation that you had would kill any microinvasion that was in the breast. It's not something that's usually in both breasts. In fact, most breast cancers are only in one ductal system in one breast. They're not all over your breast. So it's not like the other breast is marching along and doing the same thing. So I actually would not worry about the microinvasion very much. It's not a big deal, and it was probably completely treated by the radiation that you received. Marianne is a 14-year survivor, and she had DCIS on one breast, and DCIS now is when it's stuck in the milk duct, ductal carcinoma in situ. It's in the site, and it hasn't gotten to microinvasion yet, or at least they haven't found that. She had a lumpectomy, and she's worried if she keeps having mammograms up to age 90, and she's planning to live to age 90, that maybe the cumulative radiation will be bad for her. But the thing is, she's actually about 50. And the risk of the radiation with mammography is higher in the younger woman, in the immature breast, and less high in the, quote, mature breast. And so I think she doesn't need to worry about that. The chance that either her DCIS is going to come back, it was 14 years ago, or that she's going to get another cancer is fairly low. In fact, the fact that she's 50, she's about to go through menopause, which will reduce her chances of having it come back again because she'll have less hormones on board. So I don't think you need to worry. I don't think she needs to worry about the radiation, and I don't think she needs to worry very much about having a recurrence. Linda asked about receptor status. She said, on my slide, I showed the gray area where you could be estrogen positive, progesterone negative, HER2 negative, and what happens with those people. Generally, the people who are estrogen positive, even if they're progesterone negative, are treated with hormones. But this is another case where it's a good idea to do a test like the Oncotype DX test, which can parse that out and say, this group of people who are estrogen positive, progesterone negative, will do fine with hormones, and this group won't. I think over time we're trying to understand how the progesterone and the estrogen work together and how these receptors relate, and we'll be able to better parse out that. But at least with Oncotype DX, you can tell who should get the chemo and who shouldn't. And obviously, if it's HER2 negative, you would not give Herceptin. Mariella is a survivor who's been in remission for 18 years. Congratulations. And she was stage 3 at the time, which just shows you that stage 3 is not a death sentence, and that there are many women alive and well years later with stage 3 breast cancer. She wants to know about what kind of exercise, and she's very involved in Pilates and in a Pilates program which teaches Pilates to help stretching as well as meditation to help people recover from breast cancer. The studies on exercise really are relating to aerobic exercise where you break a sweat, and you need to do about 3 hours a week. And as somebody who does Pilates myself, I can say that I do break a sweat when I do Pilates, and so I think it would count. But it doesn't matter what kind of exercise you do, whether it's Pilates, whether it's yoga, whether it's walking, running, swimming, all of these are going to be beneficial. And in another question we talked about, somebody asked about weightlifting. There is data that women who lift weights can get more muscle strength, and initially we were very worried that this might increase lymphedema, and now several good studies have been done showing that it doesn't do that at all. So weightlifting is another thing. Ballroom dancing also you could do. Anything that gets you up and moving and gets your heart rate up counts as exercise. So you have to pick really based on what you'll do, not on what some study shows, because even though it might be slightly better, if you're not going to do it, it's worthless to you. So pick something you can do. And I always say the reason I exercise and I run as well as do Pilates, although very slowly, is because after I run, for the rest of the day, I feel morally superior. And that's even worth more than decreasing breast cancer. So anything you want to do, you should do. And this takes care of Kath's question as well in terms of weight training and that. Next question is, how young should you start getting breast mammograms? You should start getting, we're screening the whole population starting around age 50, because at age 50, the benefit outweighs the risk for almost everybody. And it has to do with the fact that the breast tissue is very dense when you're young. Cancer is dense, so it's like looking for a polar bear in the snow. And it's not that we want to deprive young women of their God-given right to be radiated. It's more that it's just not a very good tool in young women. So for young women, I think what they have to do is weigh the risks and benefits in their situation. You might want to have one mammogram in your early 40s, and if your breast tissue is very dense, then that means you have a higher risk of getting breast cancer, so then you might want to continue with either ultrasounds or mammograms every couple of years. If you have a strong family history and you have a dense breast, or if you've had abnormal cells on a mammogram, those might be reasons that you would continue to have mammograms and maybe ultrasounds or even MRIs. But if you are not at high risk, then starting at 50 is really fine. And meanwhile, though, the biggest problem with young women is that when they feel a lump and they go to the doctor poo-poos it and doesn't do anything. And so we need to notice, be aware of our breasts, and if we feel something and the doctor doesn't pay attention to it, go to another doctor. These days, we don't have to do surgery to do a biopsy. You can do a core biopsy and just take a little piece out, and you can get an answer, and there's no excuse for ignoring a lump. When we feel our breasts, we're feeling from the outside in and the inside out. And so we have a much better sense than the doctor does. And so pay attention to that inner voice and that inner feeling you have that it's not right, and don't take the reassurance of the doctor. Get it checked out. Okay, another question has to do with, how is the Army of Women different than the sister study? Great question. The sister study is a long-term study looking at women with breast cancer and their sisters and tracking them over time, and they're looking for environmental causes of breast cancer as well as genetic causes, because we know you need both. When we launched the Army of Women back 3 years ago, the first study we recruited for was the sister study, and we in fact completed their recruitment so that they could close the study. So it's a great study, and it's good for people to be in it. The difference with the Army of Women is you're signing up not for a study. What you're signing up for is for us to tell you about studies. You're signing up to be on an email list. And then when scientists come to us with studies like the sister study or other studies, we e-blast them out to everybody on our list. And those of you who fit the criteria and want to be in it, RSVP, and we make sure you fit, and then we send you to the scientist for the study. So, and if you don't fit, we hope you pass it on to somebody else who fits. So we're not just doing our own studies, which we do occasionally, but we're trying to help scientists around the country and the world to move their research from rats and mice into women, where we can actually find answers that are going to relate to us. We're really good at curing cancer in mice. The problem is mice don't get breast cancer unless we give it to them. So if we're going to figure out what the cause is and how to cure it in women, we got to study women. And the Army of Women is a way for you to be part of some of these studies. But it's a little bit like eHarmony. You don't have to date every one of those guys. Well, you don't have to be in every study. If there's a study that involves drawing blood and you say, I get squeamish when my blood's drawn, don't do that study. There may be another study that's an internet questionnaire that you feel perfectly happy with. So you get a choice, and it just lets you know about the opportunities, and then you choose. Okay, and I'm glad you asked, because I always like to plug the Army of Women. And now the last question is a good one, and it leads right into that one that we just talked about, which is something that was going around the internet about a vaccine for breast cancer. This is a study that was done by Vincent Toy at Rice University, and what they did is they took a protein that goes up when you breastfeed, but is actually down most of the time, and they found out that when you have cancer, it also goes up. So they made an antibody to that protein, and and made a vaccine out of it, and in mice, they were able to totally prevent breast cancer. It wasn't a lot of mice, and it was mice. So it's interesting, very promising. The problem with it would be it would only work for women when they had completed their families and weren't going to breastfeed anymore, because the protein goes up during breastfeeding too. So you have to wait. We don't know if it would prevent you from making milk or what would happen. So it's probably will be a better vaccine for older women than younger women. And it may or may not work in women. As I just said, a lot of things that work in mice don't work in women. But I do think that this is the direction we need to go in. We need to figure out, we have a vaccine for cancer of the cervix. There's no reason we can't have a vaccine for cancer of the breast. And we need to figure out what the cause is and how to do that. And so I applaud their research, but it's not ready for prime time by any means. And it's going to have to be tested out in a large study of women, both in terms of safety and to see whether it actually works in women the way it works in mice. So with that, I think we've covered all your questions. It's been great spending this time with you, and go to the website, join the Army of Women, go to drsusanlovemd.com and ask questions if you want, and we will see if we can't continue doing some webinars and some videos like this on a regular basis so that we can keep you abreast of all the research. All puns intended. Have a good day.